Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's call. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the conference over to Dr. Sakiba Henderson. Dr. Henderson, you may begin.
Good afternoon. My name is Sakiba Henderson, and I lead the state-based perinatal quality collaborative activities in the Division of Reproductive Health here at CDC. And I would like to welcome you to the third presentation in our second series of webinars we are sponsoring on perinatal quality collaboratives. Today's presentation is about hypertensive disorders of pregnancy and will include a discussion of quality improvement projects and recent guidelines proposed for response to and management of hypertensive disorders of pregnancy. Our presenters today are Dr. Marilyn Kasika and Nancy Peterson. At the end of all the presentations, you will have the opportunity to ask questions and participate in the discussion. A recording of this webinar will be archived and made available on our webpage at www.cdc.gov/reproductive health/maternal-infant-health/PQC. Downloadable handouts will also be made available and may be accessed by clicking the Handout tab at the upper right side of your screen and then selecting the files to download to your computer. For additional information from CDC about severe maternal morbidity in the United States, you can also go to www.cdc.gov/reproductive health/maternal-infant-health/severe maternal morbidity. Our first speaker is Dr. Marilyn Kasika. Dr. Kasika is the Medical Director of the Division of Family Health within the New York State Department of Health. She provides leadership for New York State maternal and child health epidemiology and programs, health informatics, and quality improvement. She is a board-certified pediatrician with subspecialties in infectious diseases and preventive medicine. Dr. Kasika is a fellow of the American Academy of Pediatrics and clinical professor of epidemiology at the State University of New York, University of Albany School of Public Health. Dr. Kasika has served in leadership roles in quality improvement initiatives dealing with asthma, school-based health centers, and is currently as the director of the New York State Perinatal Quality Collaborative. I will now turn the presentation over to Marilyn Kasika.
Thank you, Kiba. So I'm going to talk about guidelines that we developed over the past year on hypertensive disorders in pregnancies for healthcare providers. So New York State has a comprehensive maternal mortality review process that was implemented in 2012. And we have a committee, an expert review committee, that advises us on what we find. This committee is multidisciplinary in nature, and we have a lot of participation from the committee. It really represents over 20 professional organizations and hospitals across the state. I wanted to give you an example of some of the associations that work with us on this process. And we try to include everyone who might see a pregnant woman or a woman who was intending to get pregnant. So we, of course, work with ACOG. We have our New York State Nurses Association. We included midwives, family physicians, anesthesiologists. We have the Dietetic Association, since obesity is such a large issue in what we see, emergency physicians, et cetera, as you can look at. So this committee reviews the aggregate data that we present to them from our review process and then discusses the trends, what are the emerging issues that we're seeing, and then makes recommendations for prevention measures and how we might be able to improve care and the education to decrease our maternal mortality rate. Through the review of our data, we saw that the top 4 causes of maternal mortality were hypertension, hemorrhage, embolism, and infection. And the department had already previously worked on hemorrhage earlier and had developed a poster that is being used by facilities. So it was decided that hypertension should be the focus of our next efforts. When we looked at hypertension in general, we saw that hypertensive disorders are 5 times more prevalent in maternal deaths, as you might see in the population. And we looked at this through reviewing our birth records versus what we were finding in our maternal mortality reviews. We had a rate of, we saw 26% of our deaths were associated with hypertension, whereas 5% of women who had given birth and had a live birth recorded. We also have begun looking at severe maternal morbidity within the state, and we found that hypertensive disorders contribute to almost a quarter of severe maternal morbidity. When we looked at our data for 2008 to 2011, we saw that we have a rate of 274 per 10,000 deliveries of severe maternal morbidity, and of these, 63 per 10,000 deliveries was associated with hypertension. So once the expert review committee, looked at the data with us, we decided that a guidance document for healthcare providers who care for women in a variety of clinical settings, not only obstetricians, but say an emergency physician who might see a woman who comes in, or a nurse midwife, or a nurse. We wanted to make sure that they were able to recognize and understand what should be done. So when hypertension was identified as a priority, we looked to this group for volunteers to help us develop these guidelines for the evaluation and management of HDP. So as I said, it was for a variety of clinical settings, and we wanted to promote quality services and enhance communication among providers, because what we were finding is that a lack of communication was really part of the problem. The committee went through this process by providing a summary of existing guidelines and documents, and then subcommittee consensus. So they did a thorough review of what was already out there. And we began this process, and we knew this was not to replace clinical judgment in caring for women, because certainly a guidance document can't do that. But we just wanted to make sure that everyone had the appropriate tools available and the most current knowledge. The review and comparison of the guidelines included practice bulletins, committee opinions, and then some additional literature recommended by subcommittee members. So if something new had come out during the process, that was also put in the review. The guidelines that were considered, we used guidelines that were already out there for the United Kingdom, from Canada, from Australia, and the New York State Department of Health had already published a paper on hypertension in diverse populations that focused on the Medicaid population. We also reviewed ACOG documents that were out there that addressed perinatal care, the management of preeclampsia and eclampsia, and chronic hypertension. So the subcommittee discussed the findings of the draft documents, and an executive summary and narrative document was put together and distributed to the subcommittee. There were a lot of iterations of this within the committee and then back to the larger maternal mortality review committee for sign-off. And also there was a review process internally at the Department of Health. Some of the content of the guidance document we initially started out with definitions. We wanted to make sure that everyone understood how we were defining things so that when we were talking about a certain subject, everyone understood and was on the same playing field. We began with assessment, and we talked about how to actually perform blood pressure measurement. You know, what is the technique? What kind of conditions do you conduct it under? And we also talked about proteinuria screening. There was, you know, a lot of information on risk factors for preeclampsia. How do you assess? You know, what is the baseline renal function? What type of laboratory testing? How do you reduce risk for hypertensive disorders for high-risk women? We talked about low-dose aspirin use, the ambulatory care of chronic hypertension, so women who already have hypertension, how are they managed? We also wanted to talk about diet and lifestyle in association with the whole concept of well woman care. When we talked about treatment, we wanted to make sure that everyone understood, you know, the target and thresholds for non-severe hypertension and severe hypertension. There was a discussion of treatment using labetalol, nifedipine, and methyl-dopa, and also surveillance for hypertension, both maternal and then fetal, as far as frequency of testing and monitoring. Some of the inpatient prenatal care issues that we talked about were indications for inpatient. What kind of hospital protocols were there and what were appropriate? What kind of discharge instructions should be given to a woman? Make sure that there's communication among healthcare providers, patient, and family. Some sample order sets, seizure prophylaxis and management, and we also talked about HELP syndrome. Other topics included antenatal steroids, fluid balance, and thromboprophylaxis. As far as delivery and intrapartum care, discussions included delivery timing, the mode of delivery, anesthesia, and then postpartum care and risk communication. So the document was meant to be as comprehensive as possible. We wanted to focus on outpatient and inpatient to make sure that we were reaching as many providers as we could. So this, the guidance document was rolled out at our annual maternal mortality review meeting, and we have posted this guideline on the New York State Department of Health website. We've also widely disseminated to hospitals across the state, to health plans across the state, and our partner organizations have also linked to it from their websites. As a part of our rollout plan, we always wanted to go the next step then and to see what kind of point-of-use tools would be useful in association with the guidelines. We all know that sometimes guidelines are put on a shelf and never seen again, and we didn't want that to be the case with these. So as we were going forth with these discussions, we were fortunate enough to apply and receive an award from AMCHIP as part of the Every Mother initiative. And this award was being used, they wanted to focus on translation of activities from an issue that was identified through maternal mortality review. So I think that this fit very well with sort of the process that we were going for. So since we had identified hypertension, we had developed the guidelines, and the next step was translation for us. That is what we focused on in this grant. So some of the things that we are working on currently and are nearing an end in are we're putting together a provider training for continuing education, so a PowerPoint presentation that will be narrated, that will be online, that will be presented initially and then archived so that providers can take it when it is convenient for them. Other tools that we're working on are an outpatient tool, sort of demonstrating the highlights around measuring blood pressure. And we think that this tool will be useful in the outpatient setting, in the clinic setting, private practices, as well as within the hospital. We're working on an emergency department tool. There's an algorithm that was developed by CMQCC that you'll probably hear about that we are adapting for New York State, as well as a preeclampsia early recognition tool. And we're also working with the Preeclampsia Foundation as far as a patient education tool that will focus both on pregnant and postpartum women so that they understand this sort of symptoms and signs of hypertension and know to contact one of their healthcare providers. So as you can see from this slide, California has developed these tools, and what we are doing is working with them to adapt them for New York State. So I think this is a great sharing opportunity, and we certainly appreciate the efforts that went into these tools. The other piece that we are doing, since we have the guidelines, we'll be developing these tools, is that through our perinatal quality collaborative, our obstetrical improvement project, we are going to incorporate what we've learned about this morbidity and mortality into that project. So we're working in collaboration with the New York State Partnership for Patients, which is a CMS-funded initiative within our state that we work with, to incorporate hypertension and hemorrhage into our project. We're doing this through curriculum development so that we're going to put it in the collaborative model. We've already begun coaching calls with them, and we're having a learning session the beginning of April. We will have educational webinars on the topic, and we have developed a process and outcome measure related to both topics, but for this, we have one around hypertension that they will begin collecting data. So I think that this is sort of a continuum of the process that we began by identifying an issue. We developed guidelines. We have point-of-care tools, and now we're going to be working specifically with our facilities to put these tools to use and hopefully improve outcomes in hypertension. I want to acknowledge the help I had with the whole project, certainly, and with this presentation specifically, Dr. Lazarou and Kristen Lawless, who are both integral to this presentation. So I want to thank them for their efforts. So thank you for your time, and I'll turn it back to Kiva.
Thank you so much, Marilyn. That was an excellent presentation. Our next speaker is Nancy Peterson. Nancy Peterson is a perinatal nurse practitioner who for the past 30 years has performed a variety of roles as a labor and delivery nurse, nursing faculty, clinical nurse specialist, childbirth educator, and sexual assault nurse examiner. She completed her BSN in nursing at Point Loma College in San Diego and her MSN at Regis University in Denver. Currently, she is a director of perinatal outreach at Stanford University and the clinical program manager of the California Maternal Quality Care Collaborative. For the past 2 years, she has co-chaired the Preeclampsia Task Force to develop a toolkit to improve the early recognition and treatment of preeclampsia, which was released in January 2014. Most recently, she has been the co-chair of the California statewide Preeclampsia Collaborative, involving 25 hospitals to implement the toolkit and collect data with the goal to reduce maternal morbidity and mortality associated with preeclampsia. I'll now turn the presentation over to Nancy Peterson.
Thank you so much, Kiva. Can everyone hear me all right?
Yes.
Oh, okay. Thank you so much for the opportunity to share our work with all of you. It has been an amazing process, and it's really been over the last year doing the collaborative with our hospitals. We have been able to realize such a great improvement in processes and outcomes in our 25 hospitals. So I'm going to share what I thought I'd do is briefly go over kind of our process with the pregnancy-associated maternal mortality review and how we've used that data to drive the development of the toolkit, and then give you some highlights from the toolkit, because much of what we did is similar to what Marilyn just described. We really used ACOG guidelines to guide our toolkit management strategy, but also just to share some highlights of some of the tools that we developed, and then end with a little bit about the collaborative and show you some preliminary results that we have so far. So I just want to acknowledge, that this was a process that involved numerous people throughout the state of California, just experts in their field, very much multidisciplinary. We partnered with the Preeclampsia Foundation so that we really made sure we got the patient perspective and included that in the development of the toolkit. We had just a wonderful group of people that really stepped up to the plate, and I'm just so proud to have been honored to work with them. So initially, this is probably not new news to you, and I'm sure many of you have already seen this slide, but this is our California maternal mortality rate over 30 years from 1970 to 2010. And as you see, from 1970, the trend was downward until about 1985 or 84 when it started to move upward. And the state of California became very concerned about that. And in 2006, basically, decided to form the California Pregnancy-Associated Maternal Mortality Review Committee that started reviewing cases from 2002 to 2004 was the initial cycle. And so this process really has been where the cases were identified through the state and OSHPD data and ICD-9 codes. They collected all the information, got the charts of all the maternal deaths that were pregnancy-associated, and we formed this committee of, again, experts from throughout the state that was multidisciplinary. So we had anesthesia, cardiologists, MFMs, nurse midwives, clinical nurse specialists, staff nurses. I mean, we basically had everybody that could be related to it, anesthesia. And we reviewed each case very thoroughly and determined the cause of death, and then asked, based on all of the review information that we obtained, what were some of the contributing factors to that death? And out of those contributing factors, what quality improvement opportunities were there? And we actually asked the committee to rate whether or not there could have been a chance to have altered the outcome if the management had been different, and I'll show you some data from that. So from all of this data, then, we decided which toolkits we would do, and hemorrhage was first, and many of you have already implemented or started implementing the OB hemorrhage toolkit, and preeclampsia now is just getting going. And our next one is in development, and that will be a cardiovascular toolkit. So when you look at, this is the California PAMR, which is the Pregnancy-Associated Maternal Review Committee, causes of death. This is the top 5. You'll see that cardiovascular disease is actually our top cause of death. However, preeclampsia was second with 25 deaths, or 17% of all deaths were from preeclampsia. And when you looked at that thing about grouped cause of death and was there a chance to alter outcome, you can see that preeclampsia, eclampsia, deaths from that all of the deaths had at least some chance to have altered the outcome, every single. And even though the numbers are small, 25 deaths out of 145, still every single one had some opportunity to have changed or altered the outcome. So we really found that this was something we really needed to focus on. And as you know, I mean, even though the number of mortalities with preeclampsia is very small, it's really the tip of the iceberg, and underneath that is all of the near misses, which we estimate about 400 a year, and serious morbidities is about 3,400 a year. And so this is where we chose to really focus the toolkit on, and to get the biggest impact in outcomes is focusing on the near misses and serious morbidities. So the other thing we looked at is not just women that had diagnosis of preeclampsia, but women that had diagnosis of hypertension, because in California that trend is really escalating as well, up to 6.3, which is in line with the national average of 5 to 10% of all pregnant women have hypertension. So in our cohort from 2002 to 2004, which again was 145 pregnancy-related deaths, with 17% were grouped as preeclampsia, eclampsia. But when we looked overall, 39% of all of those deaths had a diagnosis of hypertension somewhere in their medical record, whether it was in the inpatient, prenatal period, or pre-existing chronic hypertension. So that is a huge area that we need to focus on. And when you look at hypertension morbidity, this was a graph that we put all the categories of hypertension. It was using our linked data set. And comparing, if you look at the two categories of eclampsia and severe preeclampsia, compared to those women who had no hypertension, the actual severe morbidity rate was 26-fold in women that had eclampsia and severe preeclampsia over those women who had no hypertension. And even women who had just any hypertension diagnosed had a 7.3-fold increase in serious morbidity compared to those women who had no history of hypertension. So again, the morbidity is really significant, and we can really make an impact on that. And then when you ask, what do women actually die of when you talk about preeclampsia? Well, it's generally, we found it in our cohort, as well as I'll show you the next slide with what the CDC found as well, that 87% of our women, or 64% died of stroke, and out of those, 87% were from hemorrhagic stroke, and that goes along with the national findings as well. And this was the CDC review of 14 years of coded data, over 4,000 maternal deaths, and about 19, almost 20% were from preeclampsia, and as well, they found that 90% of all of those deaths were also from hemorrhagic stroke. So we also looked at what factors contributed to the deaths, and we had a whole list of factors that we kind of rated. And if you can see that under the healthcare professionals, 96%, basically 24 out of those 25 deaths, had some healthcare provider-related issue, and most of those, 92%, were related to delay in diagnosis. That for some, they were just not managing these patients quickly and identifying and recognizing the disease. And so because of that, also, there was a lot of ineffective treatment. 79% of the patients did not get the treatment that they needed in a timely manner. There was also some patient factors. 64% of the cases had some issues related to, many of these patients had a delay in actually seeking care. Many of them came in post-delivery to the ED after being at home for several days with severe headaches and didn't know that they were supposed to, notify a healthcare provider. There was a lot of, just not enough education. They were not given any written information about what symptoms they needed to notify someone right away with. So there was a lot of that patient education information that came out of these cases as well. So out of that whole review of the data, we really came up with some quality improvement themes related to preeclampsia that we focused on. And that was really, again, the early recognition and response to clinical triggers. Because on many of these cases, in fact, almost all of them, we saw that despite triggers that clearly indicated that the mother was seriously deteriorating in her condition, the healthcare providers really either didn't recognize it or didn't respond in a timely manner. And it led to numerous delays, not only in diagnosis but obviously treatment. We also found that there was a huge issue with accurate blood pressure measurement. And this came about with actually in many of my, as I'm going out through the country talking to people about blood pressure control and asking nurses really, how do you take a blood pressure? What we've been finding is that many nurses, even though initially they take a blood pressure with a patient sitting upright, they often will lay them in a lateral position and retake it, and lo and behold, the blood pressure is now normal or lower. And so we saw a number of cases that patients came in for an induction for preeclampsia, and after repositioning them in a lateral position and their blood pressure lowering, were sent home, canceled the induction and were sent home to come back with severe morbidities or stroke. So we recognize that we really need to educate providers and nurses about the accurate blood pressure. And when we're really talking about comparing apples to apples, when you're looking at prenatal records and you're looking at trends and you're comparing it to what you see now, most people in the prenatal setting are sitting upright, getting their blood pressures taken, and we need to kind of continue that same continuity of accuracy in the hospital setting. And then initiating hypertensive meds early and aggressively. We also recognized that we needed to really focus on improving coordination of care through not only multidisciplinary management, but also between units of the hospital like ED and labor and delivery and postpartum, and certainly the ICU if any of our patients end up there, and also between hospitals because, again, there were numerous transport issues with patients arriving in a rural hospital with no resources to really take care of them and certainly no consultative specialists there to manage these patients, and didn't recognize how important it was to transport them to a higher level of care. So we really need to work on that aspect. And then improve postpartum follow-up care, which I'll talk about in a few minutes. And then again, huge about we need to do a better job with educating our patients and using appropriate literacy levels to do that. So I want to share with you a few highlights and clinical pearls from the toolkit. Basically, some of you may have already downloaded it. If you haven't already, I encourage you to. I'll give you information on how to go about doing that. But basically, we started with trying to keep it pretty focused. But as you can see, we really kind of got carried away because we recognized that everything was so important. But we really focused it on the introduction is really kind of the background information, and we talked about patient care and treatment recommendations, which really covers a huge spectrum of pretty much everything related to preeclampsia. And then we included a chapter on emergency department and non-obstetrical visits, again, to really focus on the need to work with our ED colleagues to make sure that we communicate effectively and that we're basically, no matter which area that patient arrives or is located, that we're all using a standardized approach to management of these patients. And then a whole chapter on education and patient information. So this is actually came right out of the toolkit, and again, it really stresses the point about importance of making sure that everyone is taking an accurate blood pressure measurement and is consistent. So all of our collaboratives, and I'll talk about the hospitals, started at the very beginning with education to their nursing staff about being accurate and being consistent and not repositioning laterally to obtain a lower blood pressure. So we talked a lot about that. And then we recognize, obviously, that you need to have some kind of an organized tool to help people identify the clinical signs or triggers that help you with the early recognition and to avoid that delay in diagnosis and treatment. So we utilized the United Kingdom MEOWS tool, which was the modified early OB warning system tool that they developed. And we kind of used that as our guideline and adapted it to this. And we really wanted to look at something that, again, would help us kind of as the disease progresses from kind of that mild to evolves to more severe, to get people to start to recognize and intervene in a timely manner. As part of this tool, the next slide is a continuum of the tool, so that basically if all of your triggers are in the green mode, then it's normal and you proceed with your normal protocol. However, if you have any triggers in the yellow columns, and I know you didn't see that fast enough, but it is in our toolkit that you can look at. If you had one trigger, you need to notify your provider. If there's more than two, we give you some guidelines as far as what you need to do next. And again, you need to make sure that the physician is aware that she's moving on that continuum to more severe. And then red is, again, any one trigger in any of these. You get an immediate valuation, consider transfer to a higher level of care, and it requires a 1-to-1 staff ratio. And then if there's triggers under each of these areas of awareness, blood pressure, chest, or respiratory status, then we give you some guidelines of what you need to do next too. So this is, again, there's no validated tool. This is kind of a pilot. Some of our sites are piloting this now, and I'm hoping to get more better outcome and see if we can get this validated, but it's a start anyway. The other thing that became very clear as we were looking at our data was the timing of pregnancy-related deaths. And again, this was in the 2002 to 2004 cohort. And as you can see in this bottom table here of preeclampsia deaths, 68% of them were actually died within 4 days of delivery. And 98% or the 96% occurred within 42 days of delivery. And only one death actually occurred as an outlier way out to 6 weeks or longer. But all but three of the deaths that occurred of these 25 had a diagnosis of severe preeclampsia or HELP syndrome on admission to the hospital. So it really pointed to the fact that many of these women that were dying within 4 days had already been discharged and were coming back through the ED and ended up, and one of our expert panel members as well as on the task force was an ED physician who really gave us a lot of valuable information about the realities of the ED, and that many of these women, unless there was something really, they were noticeably unstable, sat in a waiting room for this 8 hours, sometimes with severe range blood pressures, and were not being seen or triggered an immediate kind of coming to the front of the line. So it really pointed to the fact that we really need to work with our ED colleagues to make sure that they identify these women early. And also many of them were coming in with their chief complaint of a headache, and about 80% of them actually had a headache as their chief complaint and ended up sitting in the waiting room and stroking. So early follow-up for all of our patients with preeclampsia, so that anybody who was diagnosed with preeclampsia in the hospital setting and was sent home on medications needed to be seen within 3 to 7 days of discharge. And then if they were not on medication but they were diagnosed with preeclampsia, they needed to be seen within 1 to 2 weeks so that they could be followed up very closely, since many of these patients, again, were the ones that came back through the ED and died. And then any patient that presents to the ED in the initial postpartum period or up to 6 weeks, really we encourage them to initiate and get OB involvement early on, because again, many of them were not even notifying the OB that their patient was there. So our treatment recommendations, again, I'll go through these very quickly because there are a lot of what Marilyn had already talked about, but really the focus of the management of preeclampsia was really to focus on recognizing it and not to ignore some of those clinical signs or the triggers that we saw time and time again in reviewing the maternal deaths, to treat and control the blood pressure in a timely manner and aggressively, giving mag sulfate for seizure prophylaxis, delivery at 34 weeks for severe preeclampsia and 37 weeks for preeclampsia, those diagnosed with preeclampsia, and then postpartum surveillance and treatment. So these are the areas that we really focused on. One of the key clinical pearls that I mentioned was really a lot of these patients came in with very vague symptoms. And again, 80% were with headache, but some of them came in with just abdominal pain, shortness of breath, generalized swelling, and, I just don't really feel very good. And what we recognize is that, we really need to alert people that even though many of these, you can easily say, well, you're pregnant, those are kind of normal, common signs of pregnancy, we really have stressed to our collaborative members that at the very least, if these patients come and present to the hospital setting or even to the clinic, that a PIH panel or lab panel should be initiated before you discharge them home, just to really rule out that this is an atypical form of preeclampsia, or at least to pay attention to them. So our initial key clinical pearl, as far as the initial first step in decreasing morbidity and mortality, is giving antihypertensive medications within 60 minutes of documentation of a persistent, and that is with more than 15 minutes is the ACOG definition of persistent severe range blood pressures of greater than or equal to 160 systolic and we used 105 to 110. We decided to lower our threshold just a little bit on the diastolic and give them a little wiggle room to treat. And then ideally, the med should be administered as soon as possible. So we started with our collaborative with a very lofty goal of giving antihypertensives within 30 minutes. And we kind of gave them a wiggle room of 30 to 60. But at the outset, 60 is kind of the maximum. And what we found is we actually have a preeclampsia toolbox that I'll show you in a minute that we implemented at Stanford and many of our collaborative hospitals as well to facilitate really getting these medications in very quickly, because what we found is many IV antihypertensive meds were not normally stocked in labor and delivery units, and they had to call the pharmacy, and it took quite a while to get it up. So we developed this preeclampsia box, which is similar to the OB hemorrhage kit that many hospitals have implemented to facilitate early rapid treatment. You're probably familiar with the Martin stroke data, and this is kind of what gave us some insight into, really if we're really trying to prevent stroke, which is the most severe, most of our deaths were from stroke, and you look at his data, 100% of the women, and again, numbers are very small, but 100% of the women have blood pressures greater than or equal to 155, and 20% versus 12% had diastolics between 105 and 110. So when we came up with our guidelines, we actually are using ACOG of systolic greater than or equal to 160 over 110. Repeat the blood pressure in 15 minutes, and if it's still in that severe range, then you treat them within 60 minutes, but we were saying ideally as soon as possible. And we've had many of our collaborative hospitals have been able to manage getting it in within 30 minutes. So it is possible. But then we also said that, there's some alternative triggers that it's okay, or you can consider giving it with a systolic greater than or equal to 155 over the 105 to 110. So we kind of gave them that option. Another key clinical pearl is, again, using MEG sulfate therapy for seizure prophylaxis in all women with severe preeclampsia or with severe features. And it can be considered in patients with mild preeclampsia, so we kind of leave it up to clinical judgment, but that it was still an option. And what we found, just as a side note, it was interesting when we were first starting the collaborative and kind of having some of our calls and seeing what barriers people were up against, is that many of our sites were reporting that many of the physicians just started MAG and did not want to consider antihypertensives because they, made the assumption that starting MAG would actually lower the blood pressure. So we really had to focus on some education with that as well, that MAG sulfate is not an antihypertensive medication. Move from there. This is an example of our emergency medical box. And again, the idea was to have everything that you need. If you have a person that comes into the unit with severe range blood pressures, you have your loading dose of MEG, you have the IV tubing, IV bottles, everything is already there, ready to go. You've got your IV medication, whether it's IV labetalol or hydralazine, depending on what your hospital facility uses. We also had PO nifedipine, so if you can't get IV access. So basically everything is in this box contained, and we've used it actually quite a few times, and it's made a huge difference in our ability to get them managed very quickly. We also know that using preeclampsia-specific checklists, doing a lot of team training and communication is really important to help. Since, again, many hospitals, the numbers are very small of these women. So we have a whole section in the toolkit on simulations and a lot of team building and team communication scenarios with SBAR, all of those things that are very, very helpful. And then, again, really the patient education strategies that are targeted to the level of education that many of our patients are at. And, again, partnering with the Preeclampsia Foundation was such a wonderful experience because they have this tool that they have so graciously allowed us to put in the toolkit, and it is available to order from them. But they did a lot of surveys and studies looking at literacy level and using a visual guide to give to some of these patients who English is a second language. And this has been fabulous. So we, at many of our sites, have gotten these on board and hand them out to all patients as well as in the clinics. So in the time I have left, I wanted to just share really quick, very quick, because I don't have much time left. I'm probably over my time. A little bit about the Preeclampsia Collaborative, and I'll just go through really, really quickly. Again, we had a multidisciplinary expert panel to cover all bases. It started in January of 2013, and it's going to August of 2014. We actually extended it a little bit. We had three main aims. Really was to reduce the rate of severe morbidities in women with severe preeclampsia, reduce the percentage of women with prolonged postpartum length of stays, and to achieve 100% completion of the deliverables that we asked of them, and that was we wanted them to do debriefs on all patients with severe range blood pressures, and we wanted them to implement a policy and procedure that was up to date. We had two outcome measures. One was severe morbidity among women with preeclampsia, eclampsia, and superimposed preeclampsia, and then looked at postpartum length of stays, defined as greater than 4 days for vaginal and more than 6 days for cesareans. Two process measures, appropriate medical management in a timely manner, and then debriefs. And then we had a balance measure that I can talk about if we have some time. So this is just some preliminary data to show you that we really have made some significant improvements. I mean, we still have a lot of work to do, but we actually have made some definite improvements. This orange line is actually baseline, and the yellow line is follow-up data. So our collaborative average for severe morbidities, now this included hemorrhage and transfusions. Our average was 21.6, and after follow-up and implementation, it was down to about 18%. But we recognized early on that including hemorrhage and transfusions, since that's the vast majority of severe morbidities, was going to give us kind of a false sense of really what we were doing. So we have the ability on our data center to exclude hemorrhage and transfusions, and you can see when we do that, that we see a lower percentage of, it's down to 6.6%, but we still have made an impact. I mean, we're down to 4.6% as far as our follow-up data, so we've lowered the average after excluding hemorrhage and transfusions. Postpartum length of stays, again, our baseline average was 7.2%, and we're now at the third quarter of 2013, we're down to 6.3%. So a little bit better, making some progress. And that was with both vaginal and C-sections clumped together. This, and looking at medication timing, we found out early on, we actually separated it out into the dark green is within 30 minutes, the lighter green is with between 30 and 60 minutes, the yellow is 60 to 90, and then the orange is greater than 90 minutes. So in this slide, you want to say green is go. I mean, that's really, we want to increase the green area. And we did do that. You can see in November of 2012, our baseline data was 39.1%. And after the collaborative in November, it was 58.1%. So we're making progress. Again, we still have a lot of wiggle room. But what we identified was there was some unmedicated group that people were reporting that these patients, even though they had severe range blood pressures, were not being treated. And so we did a survey and came up with a list of reasons why. And one of the reasons was actually that there was an appropriate reason why they weren't being treated, and that was that their blood pressure stabilized by the time they went and got the medication and went back into the room to give it. Her blood pressure was now not in the severe range, and so they withheld it. So we're tracking that category, and we'll know more hopefully in the next 6 months. Our debriefs have definitely improved to, it was 0.5% at the beginning of the base collaborative, and now up to 18%, and some of our sites are actually up to 100%. So these are some process improvements that we've identified. Again, it's critical as you begin to start a preeclampsia collaborative to make sure that everyone is on the same page about how to take a blood pressure, what the treatment thresholds are, and getting a severe preeclampsia order sets in line, as well as your policy and procedure, so that everybody, again, is using a standardized order set. One of our sites told us, you know what, they actually worked with the pharmacy and got a pre-filled syringe of labetalol, so they didn't have to worry about drawing it up at the last minute. So that was a great process improvement. We also, again, many hospitals worked with their ED, worked with their ability to communicate between the pharmacy, ED, to get medications and consults done in a timely manner. And we improved the transition of blood pressure assessment treatment from labor and delivery to postpartum as well. We initially, many of the RNs were reporting that they felt very uncomfortable giving IV antihypertensives on the unit, and many of them still had in their policies that they had to use cardiac monitoring. And so we were able to work through those barriers and address those and get that barrier removed. Again, many of these things, there's just a whole list of them, and I can't even go into them now, but it's just been a fabulous process to see how creative people have been, and we've been able to share among 25 hospitals. So these are some of the barriers, and I will end very quickly with that, is that one of the things you really have to be aware of is that data collection is so time-consuming, and it really requires administrative support. And what we found is many of our sites, because we have been tweaking our measures over this year of the collaborative and have had to ask them to go back in and re-enter their data, it has been a huge burden on our sites. And there's many coding problems, that poor chart coding of not only hypertension and preeclampsia, but also written in their chart. If they're doing a hand review of the chart, they're not seeing those key words. And so we have a huge problem with coding in our state, and I'm sure it's probably translated throughout the rest of the country. Lots of mis- and undercoding of preeclampsia. There's a lot of competing priorities now as hospitals are initiating. We have a lot of them that are implementing EPIC, and it's causing a lot of problems. There's also limited resources with staff, so getting somebody dedicated to collect the data is very difficult. And if you don't have an MD champion to work with you, it's very difficult to push through a lot of these barriers. So our collaborative, in summary, we have persevered through the measurement remodeling. We do see improvements in our outcomes and our processes. And we have, like I mentioned, extended the collaborative through 2014, and we are now planning a second collaborative now that we've kind of gotten our measures in a spot where we think we're really looking at what we want to find out, and we're going to start that in January of 2015. So I'll end here. If anyone has not downloaded the toolkit. Here's the information. If you have any questions, I'm more than happy to help you out. It has been, like I said, a wonderful experience for all of us, and thank you so much.
Thank you so much, Nancy. It was an excellent presentation. At this time, we will open up the lines for questions. Operator?
Yes, ma'am. Thank you. We'll now begin today's question and answer session. If you'd like to ask a question, please press *1 at this time and record your first and last name clearly when prompted so that I may introduce your question. To withdraw any question, you may press *2. Once again, if you'd like to ask a question, please press *1. One moment, please, for our first question to arrive.
In the meantime, I actually have a question. This is Kiba, a question for both speakers. When you're looking at morbidities, severe morbidity of preeclampsia, what exactly, in terms of the outcomes, are you looking at other than, because I know you excluded, in California, you excluded hemorrhage and transfusion. What exactly are you looking for?
Well, this is Nancy, and we actually used the severe morbidities that were in the Kuklina 2009 paper that included acute renal failure, pulmonary edema, adult respiratory or ARDS, cerebrovascular disorders, DIC, and we included actually abruptions. So we kind of have a list of ICD-9 codes of those severe morbidities that we are asking our collaborators to, that any, in the numerator, anybody with those ICD-9 diagnoses would be included in the severe morbidity measure. We have it listed out in our measurement grid.
In New York State, we use the same paper to classify ours, so it's the same.
Okay. I believe there's some questions on the line.
Yes, our first question comes from Ann Burke. Your line is now open.
Hi, thank you. Thank you so much for the presentation. When I checked the website maybe 2 weeks ago, the toolkit was still restricted to the member hospitals within the California Collaborative. Is that still true? And if so, do you have any anticipated date when it might be available to others?
It actually was formally released on January 16th, and it is available to anyone, so it's no longer restricted to our preeclampsia collaborative. So when you log on to the cmqcc.org site, you'll see in the left-hand column, it'll say Preeclampsia Toolkit. And if you click on that, it'll walk you through and just to go ahead and download it. So there should not be any problems at all. And if you are having them, will you please email me, and I will help you get that, because it's available to anyone now, not just our sites.
This is Kiba. When you actually go for that toolkit, it does require you to enter your email, I think some information for them in order to download it.
Yes, you're right, Kiba. Thank you for that.
We'll take our next question at this time from Verda Gaines. Your line is now open.
My question is, how are you involving community, faith, and spiritual-based organizations who are taking part in hospital, clinic, and community work groups and task force to address this prenatal infant mortality and morbidity problems? Oof. Did you hear it?
Yeah. In New York State, we have a system of regionalization, and we've recently funded some projects that in the region have to partner not only with the highest level of care, so we have our regional perinatal centers, which are level 4, and they're affiliated hospitals, but they also have to bring in community partners. We have perinatal networks, and we have community health workers, which are a big part of educating people, prior to coming to a facility. So we want to increase the knowledge in the community. So we're working with each of these regions could decide who needed to be at the table to do the best work. So they would bring in all of these partners at the community level to work with them.
Thank you.
Today's next question comes from Marcella Reed Warren. Your line is open.
Hello?
Hello, we can hear you.
Okay, I'm sorry. I thought I had my, I couldn't get it. Okay, well, I'm currently working OB case manager, but I still per diem in the labor unit. I've done it for 15 years, working in labor and delivery. And it's been a little different going in per diem. I didn't know if you had a suggestion on how to approach management regarding when you're working with staff where I've seen where the blood pressures are not being done appropriately, or you're assisting another nurse and you notice that they're not doing it appropriately and they're getting incorrect blood pressures, and then when you assess it's different but they don't want to address because they want to do it on the side and get normal. What would be the best approach to address those issues when working with staff when you know they're not doing it appropriately?
Well, most of our hospitals actually made it mandatory for all of their nursing staff to either attend an in-service, or they also, some of them put together a pretty quick little module that they required all of their staff to do it so that everybody was on the same page. And, you know, what happens a lot of times that you'll see, and in a lot of the situations that I've mentioned, is that hospitals and people, providers, get into that normalization of deviance in that, you know, they get away with things so many times that it's very difficult to get them to change because they just don't see any adverse effects of it. So it was really an eye-opener as we talked about this, and many of the nurses kind of, you know, held up their hand halfway like, oh, my gosh, I didn't even think about, you know, that there's a difference when you change positions and how important it is to be consistent. So I think that really is an easy way to do it, is just you can create a very quick little PowerPoint or a, you know, a module that you can require all staff to do, to complete, to just emphasize main points. And I think if you look at the chapter that we have in the toolkit, you can pretty much just pull out the key points and, you know, just have people review it and show it. What we found, though, was huge was many hospitals don't have the right size cuffs for the sizes of women that we have. And, you know, many hospitals said, you know, we have a hard time even finding a cuff, let alone different sizes. So that was a key item also, is that, you know, hospitals need to make sure that they have their units stocked with, you know, all different size cuffs. So you even need to have a pediatric cuff because we found that, you know, when we were kind of just doing it for a skills day, that many of their little Asian women need a pediatric cuff, but even a standard cuff is too big for them. And certainly, you know, our growing obese population, you need to have the large cuffs, and you need to have alternatives as far as where you can place the cuff if you can't get an accurate blood pressure on their arm, such as their calf or their thigh. So we have a little paragraph on dealing with that in the toolkit as well. But that's another huge issue, is having not only the right consistency in position, but also the right equipment, and recognizing that, you know, an auto cuff can alter your blood pressures by up to 10 millimeters of mercury by using the automated blood pressure cuff versus an old-fashioned cuff with a stethoscope.
Thank you very much.
I'm sorry. We'll take our next question from Barbara Greer.
Yes, hi. I do apologize. I wasn't able to enter until about 7 minutes after the webinar started, so now I have two questions. The first being, is any of this information broken out by race and ethnicity and age? And then the second question is it possible to get the recording, or at the very least the PowerPoint slides of this presentation?
Yeah, this is Nancy. Our slide set that we have for the toolkit, once you download the toolkit, you will have access to the whole slide set for the toolkit that you can share with
Nancy,
anyone.
I think she's referring to the slides for the presentation. Is that correct, Barbara?
Yes, this presentation, not the toolkit.
Okay, I'm sorry. At this time, I forgot to remind our participants that we do have handouts for the slides for this presentation. If you look at the upper right-hand side of your screen, there is a small icon with several pages, little white pages. If you click on that icon and select upload, select the files you want, which are two handouts available, and click upload, you'll be able to get the handouts from today's presentation. We'll also send the handouts with the evaluation that will go out after this presentation as well, and the recording of this presentation will be made available on our website.
Okay, thank you.
I'm sorry, back to the speakers.
And to address your question as to whether we break our information up by race, ethnicity, and that, yes, we do, typically. For this, we didn't include all that because it was a briefer presentation, but we look at this in that lens.
Okay.
And we do as well in California. We have all that information as well.
And will that information be available in the toolkit?
Let's see, I don't think it's actually in the toolkit, but certainly if you want to email me, I can provide it for you. I mean, interestingly, I can just say overall that for our population, the Hispanics had the highest rates of preeclampsia.
Okay.
And the highest rates of maternal death from preeclampsia.
Okay, thank you.
But I can give you more detail if you want to look at it compared to all other ethnic groups. I would be happy to do that.
Thank you.
At this time, there are no further questions in queue from the phone lines.
I actually have, Mrs. Kiba Henderson again, I have another question. You mentioned, Nancy, toward the end of your presentation that you all were also looking at a balancing measure of low blood pressures less than 80, and you said you had additional information regarding that. Could you please fill us in on that?
Yeah, absolutely. So one of the things that came out of, again, we were hearing from a lot of our sites that many of the providers were uncomfortable giving antihypertensives to patients who, were in labor because of the whole notion about causing the blood pressure to bottom out and the fetal heart rate to deteriorate. So we decided that to really look at that, is there any valid validity to that, because there really are no studies that look at that. We added a balancing measure of, so that any time they treated a severe range blood pressure with IV labetalol or hydralazine, we asked them to let us know if the diastolic blood pressure dropped below 80 by hitting yes or no, and if it was yes, were there any significant fetal heart rate changes that prompted intervention? And then the final question was, if they answered yes, did it require an emergent delivery? To really help us see that, is this a valid fear that a lot of our providers were saying that kind of held them back from giving antihypertensives. And what we found is that there is actually a significant number, and I have to pull, I don't have it with me, but there was actually, maybe 40% or so, just a ballpark figure, that actually did have diastolic blood pressures below 80 after giving antihypertensives, and we did it within an hour of giving antihypertensives, were there the diastolic to look at. But out of those, there was only really one out of all of those that had low diastolics that required an emergent delivery. And, of course, there's a lot of variables in that. I mean, we don't know if it was specifically related to the fact that the blood pressure dropped, but most of them, even with a diastolic below 80, there was no significant fetal heart rate changes. So we have one of our sites led by Sarah Kilpatrick at Cedars-Sinai. They're actually doing a study, much more in-depth study, looking at that very issue, and they're actually looking at it from the perspective of, we know that it probably makes a difference whether or not they've had, how many doses they've had on the algorithm of antihypertensive. So we're going to have a lot more robust data once they finish that study. But initially, it does not appear to really have an impact on the fetal heart rate.
Thank you. Are there any further questions?
No, ma'am. There are no questions in the queue at this time.
Okay, since there are no further questions, I would like to thank Marilyn Kasika and Nancy Peterson for giving us excellent presentations of quality improvement efforts to address hypertensive disorders of pregnancy. We would also like to thank all of you for participating in this webinar and invite you to provide feedback about this presentation and this webinar series as a whole. We will be contacting you after this webinar by email for your input. We hope that our webpage and this webinar series will facilitate exchange of information and provide and promote visibility of perinatal quality improvement activities throughout the country. We encourage you again to visit our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC to learn more about CDC support of perinatal quality improvement collaboratives. You can also contact us at the DRH info link at the bottom of that web page. Thank you again, and have a wonderful afternoon. This ends today's webinar conference.